On this episode of the ASC Podcast with John Goehle, we celebrate over 25,000 downloads, review recent guidance from CMS regarding 24-hour stays, discuss the Consolidated Appropriations Act and its impact on ASCs, discuss recent issues with ASCs, and look back on 2020 and look forward to 2021.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. The ASC Podcast with John Goehle is brought to you through the generous support of our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Intalere, Encompass Healthcare Data Solutions, Medicus IT, and BHG Patient Lending. This podcast would not be possible without the support of our sponsors, all of whom have been carefully screened for the quality of their products and services and their dedication to the ASC industry. For more information about our sponsors, visit our website at ascpodcast.com and please consider them for your center's needs.
Happy holidays and welcome to episode 120 of the ASC Podcast with John Goehle for December 31st, 2020, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, Chief Operating Officer and owner of AHS, recognized as one of the nation's leading experts in the ambulatory surgery industry. So it's a great day today. It's the last day of 2020. So happy indeed. Last day of 2020, everyone.
And let's celebrate it disappearing, hopefully, at 11:59 tonight. Yeah. We have a Zoom session already set up with the rest of the family so that we can all be together.
We'll all wave goodbye to 2020 and keep our fingers crossed for a good 21.
Yeah, this actually breaks a tradition because my sister and I have been together on New Year's Eve since we were very young. It's possible that we've never missed a year. So we'll be together. It's just we'll be separate. Definitely. But it's a interesting, kind of a melancholy situation. But speaking of melancholy, I'm a little tired today. I was in New York City yesterday, and unfortunately, as seems fitting given the way this year is, had an auto accident on the way back home. So my nice car is not so nice right now. So Sue and I have been spending the last couple hours dealing with rental cars and all those other things. So it was not a fun way to end the year. I'm all right, by the way. I no injuries to anybody involved in it. It's just that the car is a little sick. Let's put it that way.
Yeah, and you were, 5 hours away from home, so dealing with it there. And he did get home, I won't say last night. It was like 6:30 this morning. But
yeah, it's just frustrating. When you put 60,000 miles a year on a car, though, statistically, unfortunately, this is going to happen, but it's still a little frustrating. We also, but on a high note, we are well over 25,000 downloads right now. I just haven't had an opportunity to actually celebrate it. So I thought, that's quite a milestone for us. We are, of course, the most popular. We can say that because there are no other ASC podcasts really out there right now that are dedicated specifically for ASCs, targeted toward, the needs of the regulatory needs and financial needs of our organizations on a regular basis. So thank you to all of our loyal listeners. It's been a pleasure to be with you. This ends our second year, right? I'm trying to add things up. Yes, it's
I don't have a good sense
it is our
right
third year. It is our third year doing this. How did I forget that? We started in 2018.
Okay.
So, so 3 years doing that. It's hard to believe. Time has flown. Now, traditionally in December, Ambulatory Healthcare Strategies holds its year-end retreat. It tends to be kind of combined with the Christmas party. So needless to say, that did not occur this year. And what we've done in the past, those of you that have listened to us loyally, you might listen to last year's Christmas where we all got together and we sang a song. So it is well worth logging in just to hear that song. So
Jeez, I forgot that, or did I block it out?
I think you blocked it out. Yes.
Yeah, but we always enjoy that so much. And actually, we heard from Judy, our director of educational services, that she's feeling so isolated right now. So we're going to have to set up a Zoom with the company. But I think we all miss that, getting together once in a while, because where we work remotely, it's important to.
We haven't even had time to be together in Zoom lately.
Yeah.
It has been very busy. I'll tell you, most of what we've been dealing with too, Sue, has been exposure issues. Like at least 2 hours a day, I'm dealing with, one of our centers that's had some type of an exposure and walking through what needs to be done. And if it's not that, it's, PPP. It's, there's just so many issues going on right now. It is, a very challenging time. And when we do hold our retreat at the end of the year, we bring everybody on the podcast. Now, last year, as I said, we had a Christmas, we did a song, but it's been nice just to kind of look back on the year. We're going to do that today, but it'll just be the two of us talking a little bit about it, and just some lessons that we've learned, a little bit more perspective. But there is a lot of news that actually is happening, and we only recorded 3 days ago, so that's how dynamic this industry has become, and a lot going on. And then one disappointing thing, you and I, actually, when we were coming back from dropping off one of the cars and picking up another one, we were talking about the variant of the coronavirus, which, as when we're recording right now, it's been found in Colorado and then California. I think it was just announced today. So I think we're all concerned about that. They say they haven't
found it in New York State yet.
Yeah.
And I guess they are testing for different variations. I don't think specifically for that one, but they haven't found any that are different than what they expected, but I'm sure it will be. And
it's definitely a concern. I did have a conversation. We got a lot of things to go through, and I kind of think that this is somewhat randomly put in here, but we did get a call from one of our clients asking about the HHS reporting for funding that you're going to receive from CMS. If you're a Medicare provider, fee-for-service provider. The reporting period is February 15th, so you'll have to report by February 15th. The website to be able to do that reporting is not available yet. So we will try to keep you up to date on that and provide a link when that becomes available. Sue, as we were talking about earlier, can you talk a little bit about some of the exposure guidance that we've received?
The best thing to do really is to follow the CDC guidelines,
which I'll
check them periodically. We will. And, we'll update you when there's new things. It just seems like it's constantly changing. Also, just a reminder, a lot of this does have to do with using your judgment and making decisions based on the guidance. So they define close contact as someone who was within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24-hour period. And that starts from 2 days before the illness onset of the person you were around, or for asymptomatic patients, 2 days prior to the test specimen collection.
That was used to determine
the results, but when they collected it.
Until the time
the patient is isolated. Yeah. At this time also, differential determination of close contact for those using fabric face coverings is not recommended. So they don't count, and honestly, that's what it said. I don't know if they're talking paper mask coverings as well. I think unless you're in full PPE, like in a medical setting, I think you have to count it as a contact.
Right.
Even if you're wearing, a surgical mask or whatever. If you're wearing, as I said, full PPE, like in a healthcare setting, it is not considered an exposure, which makes sense. Otherwise, everybody at the hospitals, dealing with people would be out for 10, 14 days each time. And an important point is that whether you have the vaccine or not really has no bearing on these guidelines at this time. So you don't get to stop wearing your mask. You don't, if you're exposed, even after you've gotten your vaccine, it still counts. And
that's a very important thing to discuss in general, is that I think we might have mentioned this in the last podcast, but getting the vaccine is something that you do to protect yourself. It is long term. You are not going to be able to use it to stop wearing a mask. You're not going to be able to use it in order to avoid a quarantine situation or an isolation situation. So the vaccine is something that we're doing in order, for a long term purpose of reducing the chance that we're going to get exposed. So.
And hopefully with the quote unquote the herd immunity that this will change, which is why I'm saying we really have to stay up on this. But right now they're not. They're absolutely not counting it as changing anything.
Well, I'm just afraid because what we've been seeing over the last 2 weeks here is everybody is just like rushing to get this vaccine.
Yeah.
And I appreciate trying to do that. I want my daughter who works in a nursing home to get it as soon as possible. But we just have to realize that I'm hoping that they're not rushing to do it because they think they're going to be able to back off on some of these standards or start becoming looser about the way we're treating you. Still need to isolate or to socially distance. You still need to be wearing those masks. So very important thing.
So, and I do want to make the point that even reading through all of those guidelines of the CDC, that there are so many things that are still open for interpretation.
Yeah.
This is good guidance, but if you're next to somebody for 5 minutes and they're coughing or, there's just so many different ways to look at it. So go case by case and, just make sure you're really thinking it through.
Well, and we also probably have a legal disclaimer here is that obviously we're doing this based upon our interpretation of these rules. We really do encourage you to download or to go to the website that we'll link in the podcast here. And of course, we're publishing it here on the 31st. By Monday, things could have changed, and that actually is a very strong possibility, given how dynamic this is right now. On a positive note, though that wasn't necessarily negative, but on a different note,
getting away from
is CMS on December 30th, which was yesterday actually, issued QSO-21-09-ASC because we always like to use a lot of initials here, which and the subject of it was providing flexibility for exceeding the 24-hour time frame for patients in ambulatory surgery centers during COVID-19 public health emergency. So this is guidance that has been provided by CMS to the surveyors regarding an interpretation of the conditions for coverage. So in this guidance, CMS indicated it's committed to taking critical steps to ensure America's healthcare facilities continue to be prepared to respond to COVID-19 during the public health emergency. And what they want to do is they want to provide flexibility for exceeding the 24-hour time frame in ASC. So as COVID-19 cases continue to surge, CMS will temporarily exercise survey enforcement discretion regarding the 24-hour time frame to allow patients to remain in the ASC longer if needed during COVID-19, and again, specifically during the public health emergency. This is important, this applies to ASCs that have not converted to a hospital during the health emergency. So we've talked in the past about those situations in which people can apply to temporarily become a hospital. And very few have. I think it's less than 20 in the country of the 5,900 surgery centers have done that. So this is specifically for those of you that did not convert. And so just bear with me here because it is a little technical, but there might be some applicability, though I'm not sure that that's really the case. So earlier this year, CMS issued a process to allow Medicare certified ASCs to temporarily enroll as a hospital. In other words, become a hospital instead of an ASC for a period of time, and to provide hospital services. And this was done in April 2020. But those rules, when they came out, were kind of onerous because they required you to have 24-hour nursing service, even if you didn't have any patients in the center.
And the billing, and there was just a whole lot of
That's right. There were so many other reasons that we really recommended that you avoid it. And also what happened when you converted back to an ASC. On November 25th, and we talked about this a couple episodes ago, I think, on November 25th of this year, CMS revised the process to include information on policies that expanded the temporary enrollment process by waiving that particular requirement, which required that these new hospitals, these ASCs, to have a licensed practical nurse or a registered nurse on duty at all times. And this waiver requires ASCs enrolled as hospitals to provide 24-hour nursing services only when there is a patient in the facility. So it makes it a little bit more, less onerous, certainly, for doing this, allowing facilities to provide nursing services on demand through the use of a 24/7 on-call service in the event a surgeon requests to admit a patient for a required surgical procedure. So with the most recent uptick in cases, CMS is revisiting this, and they're attempting to find ways to adapt program requirements to expand capacity to treat patients during this unprecedented time. In the ASC Conditions for Coverage, Section 416.2, an ASC is defined in part as a facility at which the expected duration of services would not exceed 24 hours following admission. We know that one very well because that generates that whole 23-hour stay conversation that we frequently have. The interpretive guidelines for this section make it clear that exceeding the 24-hour time frame is expected to be a very rare rare occurrence, and each rare occurrence is expected to be demonstrated to have been something which ordinarily would not have been foreseen. In other words, you wouldn't even anticipate that. It's not something you would ever schedule. So CMS, with this guidance, indicated that for the remainder of the public health emergency, CMS plans to exercise discretion in enforcing that 24-hour limit as described there in 416.2, and to provide flexibility and to allow ASCs to keep medically stable patients not requiring hospitalization for observation in the ASC past the 24-hour time frame, and to lessen the chance of patients being exposed to COVID-19 through transfer by allowing that additional recovery time in the ASC as needed when issues arise, such as the need for post-surgical pain control or hydration, which I think is probably the most common situation that we would have. We note that this enforcement discretion does not alter whether a procedure is included on the ASC covered procedures list, the CPL, which we talked about in another episode recently, I think 2 episodes ago. Rather, it provides flexibility during the public health emergency for ASCs to keep medically stable patients for longer than the 24-hour time frame. So I think this is actually going to be very infrequent, Sue. We know that sometimes we have to send a patient to a hospital because the pain hasn't been controlled.
Yeah, and they don't really need hospital care. They just need someplace to have their pain controlled longer, or
because we're not going to be open.
They're hydrated because they're not drinking enough.
Right.
Now, what is the procedure for this? Do we know that?
Well, there isn't the guidance. I've read the whole guidance, and I will provide a link to the guidance in the show notes here. Well, let's get back to the main reason they're doing this is so that the patient doesn't have to be transferred to the hospital, and exposing them to a higher risk facility. And again, I'm nothing negative about hospitals, but being in a hospital, we're hoping that you're going to have patients that really need to be there. And if somebody's there just for pain control because the surgery center can't stay open for more than 23 hours, I mean, this is a very good thing that CMS is doing here. I just think it's very rare that it happens because we do such a good job of pain control, but those situations will arise. Now, the problem with these regs is that this is all well and good, but keep in mind, you're not going to get paid any additional money for this. So the incentive for the surgery center to actually do this, it's going to be a surgery center that really, I think we all care about our patients, but it's going to be one that understands that they're going to be absorbing a financial taking a financial hit here because they're going to have to keep staff in the center. And
I think that's the thing that, as you said, everybody wants to do the best patient care, but is your staff flexible enough? Can somebody really stay for that extra time?
Yeah. Can you imagine, you're a nurse, can you imagine getting a phone call and saying, can you stay until 6 in the morning? It just, the people that we tend to hire at a surgery center just don't tend to have that flexibility from a staffing standpoint.
But I bet sometimes it can just really be that extra couple hours.
Right.
But, I think it can be could be a really good thing.
So I think this is just a really good indication about how CMS, there's a lot of things that CMS has really done very well during this. And I think this is one of the more positive, one of the most positive things that I've seen. It's just unfortunately probably won't have a lot of relevance.
President Trump signed the Consolidated Appropriations Act 2021, a $900 billion spending bill this week. Some of the key provisions of the bill include $325 billion in aid for small businesses, including $284 billion to the U.S. Small Business Association, or SBA, for first and second PPP forgivable small business loans. And John, you'll give us some more details.
Sure. So the provisions, and again, unfortunately, Sue, I was just looking, there's still some negotiations going on here as I understand it. So, but this is what we know as of December 31st, is that the provisions regarding the PPP, which relates to both first-time and repeat PPP borrowers, have been released. So borrowers making the request must have fewer than 300 employees. You might remember the original one did allow significantly more employees. Borrowers must have suffered. So this is the big difference. Borrowers have to demonstrate that they suffered a revenue decrease of at least 25% during any one of the first 3 quarters of 2020, or during the fourth quarter of 2020 if they apply after January 1st, 2021. And the decrease is determined by comparing gross receipts in a quarter to the same quarter in the prior year. Now, that's important to note, is that it's receipts-based as opposed to accrual-based income for those of us that are geeky accountants, which it was interesting. Now, not to get our company involved in this at all, but, we receive PPP funding for ambulatory healthcare strategies. And originally, when I looked at this, we weren't going to be eligible for the second. We're not going to apply for it. But because even though our incomes remained stable, we didn't lose any clients, we didn't shut down or anything like that. Our net receipts dropped during that time frame because a lot of our clients were, had been shut down, so they weren't able to pay us during that time. So again, same thing with a lot of your organizations is that even though your business might have picked up toward the end, maybe you had a really, pretty good, you didn't quite meet that 25% drop during the second quarter because you started up in the beginning of June. I would bet that your cash flow suffered. So again, they're looking for cash flow when they're looking at this 25% drop in income. Now, the doctors will understand this, will immediately get this. The accountants are the ones like myself who got a little concerned until I read that receipt note. The maximum loan amount an eligible company can receive is the lesser of $2 million or 2.5 times the monthly payroll costs incurred during the 1 year period before the loan is made or during the calendar year 2019. 3.5 times monthly payroll if the entity's NAICS code is 72. I just saw that. I have no idea what that means. Qualified expenses paid with PPP funds are now tax deductible for both old and new PPP loans. So what this really means, to interpret this, is that we're not going to get taxed on the revenue that we receive from PPP, which was a big issue because it would have been, the government gives us this money and then they take it back, by taxing part of it. So and we believe that in the beginning that had always been the intention, but when the IRS got their hands on the regulations, they said, wait a minute, under the unless somebody revises the IRS regulations, it's not going to be tax deductible. Borrowers can now choose any 8 to 24-week period as their loan forgiveness covered period. Grants received as part of the Economic Injury Disaster Loan, or the EIDL, under the Small Business Administration will no longer have to reduce it for the PPP forgiveness. And this is this item I think is important. A simplified forgiveness application for PPP loans of less than $150,000 will be limited to borrower certifications. Now, I guess I wish I had known that when we applied for our PPP forgiveness because we filled out the big long one. But it turns out that if we waited a little bit longer, we would have been able to use the shorter form. And forgiven PPP loan funds will be considered tax-exempt income and will increase owners' basis in pass-through entities. Again, pass that on to your accountant, and they'll understand that. So this is all good news. I know that it might not be something that our particular listeners are interested in. I'm sure their accountants are going to give this information. But for your owners, you probably do want to at least discuss this during an upcoming board meeting. So let's talk about some recent experiences. This tends to be one of the more popular sections of our podcast because we talk about real life things that happen. So Sue, do you want to start with the first one there?
So in some of our recent experiences, some issues with vaginal probes have come up. So if you're involved in women's health and you use vaginal probes as part of your procedures, either intraoperatively or preoperatively, it's important to note the probes have to go through high-level disinfection. It's not enough to use a cavi wipe or some other cleaning cloth.
Or mechanism, yeah.
Yeah. Or cover the probe with a condom, for example. We've seen that. And this is an immediate jeopardy situation. So it's very important to deal with this issue. Right.
We have 3 women's health organizations that do women's health, and this has come up frequently, usually when we take on the client, when it's a brand new client, when we come in. And so the issue here is that you need to do high-level disinfection, as we indicated. But it is very common practice, even though it's not a part of the instructions for use. It is a common practice that you just wipe the probe off with a Cava wipe, or you just
cover it during use,
yeah.
and then
they cover
it off,
but it does have to go through high-level disinfection. So many years ago, we had a situation. We picked up a brand new client, and the machine wasn't used frequently. As a matter of fact, it hadn't been used in a while. I didn't even see it because it was hiding in a corner. And sure enough, the surveyors show up. They happen to see it, and they cite him. They cite him with an immediate jeopardy, which we were able to fix immediately because it wasn't even in use. But so don't take any chances on this. It just seems to pop up. I think this is the 4th time this last week, a brand new client of ours that I recognize the situation. They very quickly rectified it. So another thing that's come up again is transportation services. I don't think we've ever talked about this in the 3 years of the podcast, but over the years, and I've been in the business for 30 years now, and the issue of transportation, in other words, allowing or providing transportation for patients that come to your surgery center, has come up a number of times. And just a little bit of history is that in the past had been considered inducement. In other words, you're encouraging the patient to come to your center by giving them free transportation, giving them something for free. Or you're encouraging patients of a doctor to come to the center without the doctor incurring those costs. So that's where it would be inducement to the patient. It would actually be, unfair inducement to the doctor also. So to avoid problems with the anti-kickback statutes, or AKS, in 2017, the OIG issued a final rule, which is 42 CFR 1001.952, that added certain low-risk safe harbors under the AKS, including protection for free or discounted local transportation services that meet certain specified criteria. Unfortunately, there's about 10 criteria here, so bear with me, but it is important because I think many of you are offering these, especially in urban centers. And it's good to kind of go back and every once in a while revisit it to make sure your policies apply.
So number one, there should be a company policy that sets forth the availability of the free or discounted transportation. It is to be applied uniformly and consistently. It's not determined in a manner related to past or anticipated volume or value of federal healthcare program business.
And number two is this is very important. The transportation should be offered to all established patients, not just Medicare patients, for example, and to all physicians. So that's another thing that tends to pop up is say, I'm going to allow Dr. Smith to do it, but I'm not going to do it for Dr. Jones.
Mm-hmm. And number three, it should be for an established patient of the entity that is providing the transport. A patient can be established for purposes of the safe harbor after he or she selects and initiates contact with a provider or supplier to schedule an appointment. If a patient is not able to call a provider or supplier himself, or has otherwise given consent for a person such as a family member, a case manager, a provider, or a supplier where the patient is attending an appointment to schedule appointments for him, then a request for an appointment made on behalf of the patient is sufficient to meet this criteria. That was a long one, but I guess basically you don't want to be in.
You don't want to be advertising. Well, and that's the next one is don't advertise. But you don't want to advertise and get these people through a referral.
To your center for that.
So number four is do not market or otherwise advertise free or discounted transportation. Don't put it on the side of the vehicle that you're using for that free transportation if you have a shuttle service. And this will make it appear, and the reason for this is it'll make it appear like the purpose of the transport is to induce the patient to come to your center. And that just very clearly violates the regulations here. And you can't have any healthcare marketing, like in your brochures or the patient packet that's provided prior during the transport or at any other time by the drivers who provide the transportation.
And drivers or others arranging for transports are not to be paid on a per beneficiary transported basis.
So they should be paid like an hourly rate for the transporter or something like that. And it has to be local transportation made available only to patients within 25 miles. So you don't want to be, pulling people in from another state. Yeah. I guess another way of saying this too is you don't want to.
Often.
Yeah, right. And it's got to be reasonable. That's it can't be providing an airplane, or a luxury service to get there. It's got to be, regular transport. And of course, the transport has to be for the purpose of obtaining the medically necessary services that you're providing to them. It can't be anything else. You can't take them to the, to the grocery store afterwards on the way home.
Yeah, swing by the casino or anything like that.
Pick up the kids from daycare.
And the cost of the free or discounted transportation is borne by the entity that is providing or arranging the transport, and it's not shifted to any federal health care program.
Yeah, and that doesn't apply too much for us, because we don't have a cost-based reimbursement, but it's a good point. And the free or discounted transportation does not involve air, luxury, or ambulance-level transports. I think that's kind of obvious there.
And 10, you can have a shuttle service, which is defined as a vehicle that runs on a set route on a set schedule. Unlike the safe harbor conditions for free or discounted transportation, a shuttle service does not have to be limited to established patients.
Okay, so that was exciting. But again, something that you can, information you can use if you're deciding whether to offer transportation or just to make sure your transportation program meets the requirements. Let's take a brief break here, and then we'll come back and we'll talk about 2020 and what's coming up in 2021.
Is your ASC meeting all the infection control requirements in the new normal? Let the team of experts at Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle help you be prepared for the new normal with a range of resources. Be prepared for the infection control challenges of your ASC. Our resources include our free podcast. We'll be adding content to help keep you apprised of the changes and the requirements for infection control. And of course, the podcast is always free.
And the ASC Podcast now has the industry's leading education program for infection control coordinators, which we refer to as the ASC Infection Control Coordinator Training 2020. And we'll be updating this every year, but this training is available at the ASCpodcast.com website. This is a recording of the training program to prepare nurses for the role as an infection control prevention coordinator, or to improve the skills of coordinators that already have that position in the ASC setting. And it was recorded on April 7, 2020. This is a full-day course focused both on the basic skills necessary to become an infection control coordinator and to build on skills that current coordinators already have. Particular emphasis is placed on the infection control challenges of our current environment and preparing for more rigorous surveys in the near future.
After completing the program, attendees will receive a certificate demonstrating that they received the training. The cost of the training is $199.99, and you can get more information about it at the ASCpodcast.com website.
Ambulatory Healthcare Strategy now offers ongoing retainer-based infection control oversight, which includes an annual infection control mock survey, or more frequently, if you wish, review and revisions to your infection control program annually and as needed, annual competencies for your staff on infection control, and that's done during the mock survey, annual training on infection control, also done during this survey, and that's designed for your staff, assistance in investigations of any infections that you might have, assistance in preparing your annual infection control risk assessment, and of course access to all of the AHS infection control resources that our clients have come to rely on.
And for more information on our retainers, visit the Ambulatory Healthcare Strategies website at ah-strategies.com or call John Goehle at 585-594-1167.
So, given that this is the last day of 2020, thank goodness, I thought that we would just do a little bit of a retrospective on the year, kind of look at some of the things that we've learned from the year, and then try to make some predictions long term. Now, some of these things we've talked about in various podcasts in the past, but I just wanted to kind of put it all together in one specific segment in the podcast. I think Sue, isn't it fair to say we've learned a lot this year? Mm-hmm. And, certainly taking emergency and disaster planning more serious is definitely one of those. I mean, we've watched what happened with the hurricanes and bad weather situations. And, we said, oh, well, that happened down in Houston. That happened down in Florida. That happened, like in Hurricane Sandy, up in New York. But, I live in Rochester, New York. How is that ever going to impact me? And we clearly learned that we need to be prepared for any emergency and that something very serious could occur that would literally impact the entire nation. And,
and in ways you might not even think of, like
right.
the shortages and just so much and kids being out of school, so you run into problems with your staffing.
Yeah.
I just think we've learned a lot about how far-reaching effects of one thing can be.
Right. And when we did put together pandemic programs, you've been involved in the policies for some of those things. None of our policies ever came close to talking about
toilet paper. Nobody said stock up on toilet paper.
Or the impact on, like the shutdown or things like that. I think we just...
Transportation shutdowns.
Exactly.
Homeschooling.
A prolonged periods of time, 2 to 3 months of being shut down. Yeah. The definition of elective and non-elective procedure. I think that's another thing that's kind of come out of this is... I've said this before. I don't know if I've said it on the podcast, but I don't believe there's such a thing as an elective surgery anymore. I mean, I don't like that term because people don't elect to have have a procedure done. They might elect to have this particular alternative done compared to other alternatives, but they're, if indeed they don't need those services, then they probably, are not eligible for them in the first place. So, and that term has really done significant damage to the industry. So, I think that's another thing that we've looked at.
I think, being urgent or non-urgent maybe is one thing. But again, you can't really put a timeline on it. Yeah. That's, I think, another thing that we've really found out. There's not always concrete answers to a lot of things that we're looking for. You have to really put a lot of thought into it. I think a lot of people's QI process and board meetings will be so much stronger because they've learned how we really have to talk this stuff through.
That's right.
And make some good decisions and document the decisions we're making.
And to that point, I think the involvement of the governing body has been, we've seen that across the board with our clients, is that, up until, this year, often, the administrator talked during the board meeting and the board members, let's face it, some of them were texting, they were, looking at their phone, they were, doing whatever, and they weren't totally engaged in it because, in many cases, the administrator kind of ran the show, on their behalf. And, that, the administrator it's still an extremely important part of this, of course, but this is one of those areas where the administrator really needed guidance throughout, needed the help of the board in order to make those decisions. And I'm hoping that during this, many of your boards have become stronger as a result of that. Continuing still with the emergency and disaster planning, I think we recognize the importance of an up-to-date program. And I'm just going to tell you, if you have not updated your emergency and disaster plan this year, then you are going to be in deep trouble when the surveyors come through because unless you were able to predict everything that happened. And I don't think any of us could do that. But anything that we learn from any of these disasters, and some of the things that we've learned probably don't relate necessarily to another pandemic, but just the way we react to this type of a situation. I also feel that it's helped us to realize the importance of good financial planning. For example, I speak frequently during finance seminars about the importance of keeping quite a bit of cash on hand. And in the past, I've said, keeping 1 to 2 months of cash on hand is important. And the reason I'll say for that is, well, imagine a scenario in which you don't get you have no cash receipts for a period of time. And I can remember board members saying, that's never going to happen. Well, I told you so. I get that. That's been a good feeling for me to be able to say, I told you so. Unfortunately, that, we're one of the people that hasn't been paid as a result of their failure to have that cash on hand. But doing good financial planning, making sure you have good financial projections, making sure that you always have a good reserve of cash so that you can keep the doors open and not have to go back to the doctors and ask for additional money or go back to the bank. That's another thing that happened during this time, is that organizations that thought that they had a line of credit sometimes found out that line of credit was not available to them during it, or it was not sufficient to get through that time frame. I thought you were going to say something. Okay. So we discussed financial planning during the finance and accounting seminar earlier this month, and I really do encourage you, if you need some advice or want to think a little bit more about developing financial projections or doing a deep dive into financial planning and strategic planning that you talk about, that you listen to that. And we'll talk about this a little bit more. I do hope to have a conference shortly on strategic planning because I feel that's so important. I don't know if anybody will attend it, but it is something that I want to encourage everybody to think about, and certainly it's something that we've learned through this. I do want to point out, this is totally self-serving here, but if you do need help with financial planning and projections, feel free to reach out to me at 585-594-1167 or just email us at info@ascpodcast.com. That's really, I don't think I've mentioned this in the past, but I actually got into the ASC industry by doing financial projections for a brand new surgery center back in the late 80s. And it's something that I'm really quite passionate about. And I think I'm very good at doing it. And I think now, we're in a situation where financial planning, doing financial projections, figuring out what the impact's going to be over the next year, of changes that are likely to occur could be very helpful. Sue, how about the next item? Why don't you?
So we've learned a lot about maintaining appropriate inventory levels of critical supplies. And again, as we've talked about before, we don't want to be hoarding things and overdoing it, but the just-in-time kind of supply chain got a lot of people in trouble now. So
Especially for critical supplies. I mean, I think there's going to be, some things that you really don't need to because we still have the issue of where are we going to store this.
Yeah.
I think I was joking the other day that, I haven't seen an administrator's office that's been clean in the last 6 months, including my office upstairs, which has N95 mask, KN95. We've got so many of these things that we've stocked up and, we're not even, direct healthcare providers. I probably better not say that because now I'm going to be robbed because people.
Everybody's after them. Keeping track of the supply chain and what's happening, because there were things that were already a little bit in short supply, and then this happened, and it was impossible to get these things.
Yeah.
So
another important thing that I find is that we're much better prepared for another pandemic or another shutdown. Now, it probably sounds bad, like I'm predicting it, but what I'm really meaning is that I think that we can avoid a shutdown in the future by demonstrating, because we have been able to demonstrate that we're able to stay open safely, that we can maintain patient safety during this difficult time. And in many ways, I think we're able to do it better than a hospital. A hospital can't control many of those factors. We can keep, sick patients out of our place.
Yeah.
That's not, that's what a hospital is for, unfortunately. They're going to have that. Somebody's got to take care of them, and unfortunately, it's going to have to be in the hospital.
And I think that is something they found, that the spread is not happening in medical centers, and it's not happening in schools. So a lot has been learned.
And we've been talking a lot lately about staffing and leadership. We've talked extensively about staff shortages and how to deal with the mentoring issues and training new staff to be leaders. Sue, on the way down to New York, before I crashed my car, I was reading a book called Mastery by Robert Greene. Now, Greene believes that each one of us has within ourselves the potential to be a master. And he suggests that those that really want to succeed in leadership positions enter into a rigorous apprenticeship and absorb the hidden knowledge possessed by those with years of experience, and to surge past competitors to surpass them in brilliance. That's actually off of the cover. And he gave examples of Albert Einstein, Charles Darwin, and Leonardo da Vinci. Now, this really does sound a little over the top, and he's very engaging, and you listen to this and you're thinking, well, wait a minute, this is not for me. But the author's point is that one who wishes to excel needs to have an extended period of time with experts who can mentor him. And we've talked about this, Sue, quite a bit. And indeed, our Administrators Bootcamp is an example of our attempt, at least, to offer that type of an opportunity to, future administrators in the industry, to raise them to a different level. And I think this book provides lessons both for those of you that are hoping to get into leadership as well as those that are leaders who wish to groom the next generation. And it really points out the importance of a well-designed and conscious effort to train leaders, which, again, you and I have talked about quite a bit, is, just so often people leave the job quickly. We joke about, on Friday I left and, I was the charge nurse, and on Monday I was the administrator or the nurse manager. And that unfortunately is more often the case rather than, I've been training to be the administrator. I've been training to be the nurse manager for the last, 4 years. Really the emphasis here and the one of the points that the book was trying to make is that if you put together a well-designed and conscious program, well laid out, even written program, that's going to be a very useful. So this book was really an eye-opener for me. And as I said, I'm hoping that the Administrators Bootcamp, which we're going to be following up shortly with a Nurse Manager Bootcamp and an Office Manager Bootcamp, will provide one option. If you don't have, I think the best situation is that you have a really experienced administrator that works in your center and he grooms somebody, or he or she grooms somebody for the next 3 years. And I think that happens more frequently with nurse managers and less frequently with administrators. But
it's a tough thing, though, because often people leave without knowing that they're planning to leave in 3 years from now. And
that's just not the way our industry works, too, is that, people don't have that time frame. And during COVID, we've had a lot of announcements. A dear friend of mine was just announcing that, that he's going to leave as an administrator, and that was kind of a shocker to me. So I think that we have to find a way to do this, be it either trying to identify people within our organizations to start grooming, or to put together programs like what we're doing with the boot camp, which is, you can probably already tell I'm very, very excited about this and the possibility. But we, again, still encourage you to identify people who might be good candidates for leadership and to take time to prepare them for that position. So anything else you want to talk about last year or this year? I mean, we're still 2020. No, people won't hear this until next year, but I guess that's enough, right? So let's make some predictions. Unfortunately, these aren't any more positive, but I think one definite prediction is this isn't going to be the last pandemic we're going to have. I think we all kind of know that. I'm hoping, thankfully this has not been a pandemic with, again, not to minimize it, but the spread, the possibility of getting it has not been high. It's not the type of thing that we see in those disaster movies where, 75, 85, 95% of the population dies as a result of it. But that certainly is something that could happen. So maybe this was just to give us a little bit of taste of how, if it, even with this small of a spread or, the death rate, how bad it could be if the death rate were even 10 times what it is now, which wouldn't even get to, really 10%, I believe.
As you said, we'd be so much more ready for it as we, all the working from home and doing Zoom, all that was just new to us. When you think of how just in the few months that this has been going on, how it's just second nature to people now.
Yeah.
We're a little more prepared, and I don't think it would be as painful.
And I think, too, that we're going to find some positions that have moved off site, such as billing, coding, making pre-op phone calls, making post-op phone calls. All of those things are things that can be done from home with a good computer system. If you need the space in the surgery center and you want to hire people that, can deal with screaming children in the background or a over rambunctious puppy like us, can do that type of job. I'm excited about it because that really opens up the possibility of employing people that you've never had before. Think about even, part-time retired nurses. Maybe they just want a little additional income, and you don't have a need for a full-time person.
And you don't have to pay for the room for them to work, and they don't need to spend an hour. If you're in some place where there's quite a commute, you could be commuting for an hour or so a day, and I was going to say just how much more efficient.
Yeah, and I was going to say that's a big thing for urban situations, but we have a problem here in Rochester that sometimes people, living in the outskirts of the town, come a long way. They might live an hour and a half away from here because there's no jobs down there, but they come up here. So it's not just urban centers that are going to have that commute issue. And again, it really opens up the possibility. We know we have, shortages of staff, but some of them are out there, and maybe we can recruit. I mean, really, there's no reason why you couldn't hire somebody, in another state altogether to do some of these, those phone calls or that offsite stuff.
You've got a great staff member maybe that's moving to a warmer state, or they just want to get into a little more rural area. There may be a way that you can hang on to them and use some of their knowledge and continue.
I think we're going to have to get used to wearing masks. I was thinking yesterday, Sue, I had a mask on all day long. I was in Flushing yesterday in New York City. And the funny thing about Flushing is that in that area, people have always worn masks for the most part. Maybe not everybody, but I walk down the street and it doesn't look much different, except that the number of people on the street were much less than I'm used to seeing in that particular area. But I was thinking yesterday as I had the mask on all day long, that I was actually starting to get comfortable with it, that it's becoming a way of life now, and I'm not sure I ever got that. Would have thought that I would ever get that way. I have asthma, so covering my face has always been, restricting that airflow has always been a bit of a scary thing for me. But now I think I'm getting used to it, and I'm not complaining as much about it as time goes on. And I think it's just I don't see a light at the end of the tunnel on that one. For a while.
I think it will lessen up somewhat. But boy, it's funny too, watching TV or watching old movies or something, how it's so weird. Like I have that knee-jerk reaction that, they're not wearing, look at how close they are. And it's just so weird how it's just become such a normal thing. Yeah.
So my biggest concern is that my granddaughter is not going to know what my mouth looks like.
Yes.
All of my pictures with my granddaughter are, and of course, I'm not only am I wearing a mask, I'm wearing a KN95 with that funny looking bulge out there. So that poor baby, I
thinks her grandfather's a bird.
I know. She doesn't know. And you have the same problem because you've got your granddaughter too. But so I think. This is what really concerns me. Again, I thought I had some very positive predictions here. Maybe they get a little bit further on, but patients are going to continue to be leery about, during a crisis like this one, to come to an ambulatory surgery center. for that matter, just to leave the house. But I mean, to come to an ambulatory surgery center where there's a possibility that somebody might be sick.
But more so a hospital. So there's the good news.
So that's the good news is that it's more leery. They're going to definitely be more leery about a hospital. And again, we've talked about this, and you and I in particular have talked about how really optimistic I am in the long run about moving some of those cases that should have been moved a long time ago into the surgery center setting from the hospital. Now this is actually going to push it.
Yeah, and as they gather more data and they see how low the spread was in centers. I mean, some staff have had some exposures, but generally it was when they were in their, private lives. So I think that as this all gets digested and things are looked at as we move away from this, I think it's going to have good.
Yeah, and somebody even pointed out that maybe even temperature monitoring and doing some of that monitoring will be a permanent thing. Just making sure that people don't come in with a problem, especially if if we can't stop the different types of things. And again, we've said this before. I don't think it's going to be respectable ever again for people to come to work sick. Yeah. You're going to be, you're going to be socially ostracized for coming to. And in the past, you were praised, so that won't happen. I think there's also going to be changes in sick time programs too. We're already trying to figure out how best to. I mean, we already have problems in many of our organizations trying to figure out the mess that we created in 2020.
Yeah, and I think you've mentioned before too that probably the technology with masks and PPE is just going to improve.
Yeah. I think I'm seeing that already. Just some of the more recent masks that I've been wearing, even the paper masks have been better. They seem to be stronger. They're not they're not falling apart as easily. Certainly the cloth masks I don't think have been improving much, but and I really don't like those because I don't feel they're not frequent. They're not changed frequently, or we have no proof that they're being washed. What do you think about cleaning processes? Are we going to go back to the same old there? I don't think so. No. Don't think that those cleaning people that you hired temporarily are ever going to go away. There's definitely going to be the anticipation that in the future cleaning is going to be at the forefront of what you're doing. Another thing that we've talked about too is how important it is to not. The cleaner used to be the person that you'd put in the back of the room, and you would kind of hide the fact that somebody's cleaning. And now, as we've been saying, you want that cleaner out there,
very
obvious, being very
bright lights flashing.
Exactly.
Yeah, and the hand. But this has always been a thing. But your hand hygiene, you just want to be very obvious with it, and I don't think that's new, but it's just become more.
Yeah. I got to say, though, I'm having a problem this last week sneezing because, with my allergies, sneezing has become a serious problem. Yes. So usually what I end up having to do is I'm in the middle of a conversation and I'll have to say, excuse me, right, not COVID, say, excuse me, and run to the closest bathroom. And then, I'm back 5 minutes later after I've washed my hands and done everything else. And then usually I have another sneeze.
And you've always had that cough.
Yeah.
It's kind of a seasonal thing because of the asthma and the allergies. Right. And even before COVID, it was sort of people would move away from us.
Yeah, right, exactly.
And now it's like, oh my gosh.
Yeah.
Yeah.
The importance of an excellent infection control program and keeping it up to date. And I think we've been good about this. And I think we have over the years been kind of building this. Those that haven't listened to episode 119, I encourage you to go back to 119 because we had this wonderful interview, hour interview with Lori talking about this and the importance of keeping that up to date. But I think there's often been a thought, Sue, that people are not terribly concerned about the infection control program because in many centers, the chance of somebody getting an infection from the surgical procedure itself or the procedure itself was very low. And I've always said that that's not the total point there. And now things have kind of flipped.
Shifted.
Yeah, shifted. So no longer is it that we're not yes, obviously we're concerned about a surgical site infection, but people are realizing that infection control is not just about the surgical site infection. It's also about the possible spread of communicable diseases.
Yeah, so even if you're not doing a very invasive procedure, it's still important.
Right. And from that standpoint, it's no different if you're doing a pain management procedure, a GI procedure, or a surgical procedure. It's just with a surgical procedure that's invasive, you're more likely to have a surgical site infection, but the communicable diseases are still just as likely in all three of those settings. Also, I just really want to emphasize the importance of ongoing education for the infection control coordinator and staff. And again, this is self-serving here. Use the podcast. Most of our podcasts have some level of infection control discussions. You're going to find a lot more CAIP credits in the next year, too, as we bring Lori in and talk a little bit more about infection control and bring that to the forefront in the podcast. And also recognize, that we are continuing to offer some specialized training that's available to our listeners here also. And I'm afraid that the financial situation is not likely to be immediately resolved here. I think some centers are doing okay, especially those that have been able to bring cases over from the hospital. But I'm concerned that our financial situation is going to continue to be a problem in 2021. And a sad prediction I have is that some centers are just not going to make it, that the financial results or the financial strains that they're under are going to put them under, especially, if in the future there's a movement toward, reducing reimbursement rates, which we are concerned about with, some of the future initiatives that have been proposed for like Medicare for All or single payer health insurance, which are kind of the same thing, not quite. So we have to be ever vigilant about that. So is that enough predicting?
I think it is. Yep.
So again, we'd love to hear your thoughts. I think it would be nice to kind of sometime in the next month or so to, kind of point out some of the things that some of our listeners have brought up. We don't get a lot of feedback from listeners. And Sue, you've been wanting to do a live podcast soon. I think we might try to do that in January here before things get busier again. So in the first couple of weeks of January, maybe we'll try to find a day to do that. So let's take a short break, and then we'll come back and have a discussion regarding upcoming events in the ASC industry.
In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
Now, those of you that have been listening to the podcast for a long time, note that we have changed the words in this, because we used to say you are never alone in the ASC industry. And I think all of us can say we're starting to feel very alone lately because we can't go out to these conferences. So, but it is important that we keep you up to date with what is going on, even if it is virtual right now, and what's available too on the ASCpodcast.com website. So
the ASC Association's winter seminar is now a virtual conference. That will be January 11th, 19th, and 25th. This popular seminar, which is now a virtual event, as I mentioned, provides essential training for ASC billers and coders. During 3 afternoons in January, you'll hear from industry experts as they discuss the coding and billing updates for 2021 and share strategies you can use to maximize your ASC's reimbursements.
And ASCA 2021 is also virtual this year. So instead of just like in 2020, they've had to go virtual. And this will be held on 3 days, April 26th, May 3rd, and May 10th. And I believe those are, I can't remember what day of the week it is, but they are a week separated. The same content that they do for the annual conference will be delivered virtually. Then they have said that they want to get back to in person soon. Now, I'm on the education committee, and we have had quite a number of conversations about this, but I have still not seen an agenda. And I know I'm speaking. I've got to admit, I can't even remember what I'm speaking about. So hopefully that agenda will come out soon, and we'll be able to give more information about what's going to be available.
And the 2021 Virtual Infection Prevention for ASCs seminar is February 1st and 2nd. And Lori will be one of the speakers.
Absolutely.
Get the resources you need to develop and maintain an infection prevention program that protects your patients and your ASC. This course, which is comprised of 2 4-hour days, will also help you prepare for the Certified Ambulatory Infection Preventionist, or CAPE, exam.
And the 2021 Virtual Management Essentials for ASC Administrators Seminar is March 1st and 2nd. And the former name for this was the CASC Review course, by the way. So the CASC Review course has changed its name, a little bit of the content, too, into the 2021 Virtual Management Essentials for ASC Administrators Seminar, a little bit longer. And I'm one of the speakers. I'll be doing the financial section of this. As I said, it's March 1st and 2nd. So ASC leaders must be well informed and prepared to meet all the applicable federal regulatory requirements and accrediting organizational standards. Hear from expert faculty with extensive experience in ASC management as they discuss what ASC leaders need to know about compliance, finance, and quality management.
And the credentialing workshop that we recorded live on December 8th is available by going to the ASC Podcast website at ascpodcast.com.
And we are getting a number of people that signed up afterwards. We had a lot of people that attended it, but it was a very well-received workshop. It's really, a seminar, I guess, is the term that we use for it. And it provides, it's really designed more for people that are in the weeds in credentialing. So, use it to train your credentialing coordinator on how to do proper credentialing. And administrators need to have it too so that they know what their credentialing coordinator is doing. And, of course, probably the most exciting thing that's been going on is the Administrators Bootcamp. I can't believe it's only about 3 weeks away. Prepare for the challenges of ASC administration by participating in the ASC Administrators Bootcamp. And there is only one slot left in the winter cohort. So another one is scheduled for July, and more information will come out after this one is done. And also, we are going to be working on another Administrators Bootcamp program that'll be more virtual. In other words, instead of including a live section, it'll be a mentored program with recording. So that'll be available throughout the year. So there'll be a couple different options available for administrators depending upon the way in which they want the material to be delivered. The bootcamp includes reading materials, virtual private consultations with myself, and an intensive 4-day virtual conference presented in January 2021 from January 26th to the 29th. The program is really designed for new administrators that wish to enhance their skills, and administrators that wish to prepare for certification. The ASC Administrators Bootcamp is the industry's most comprehensive preparation for the role of an ASC administrator. So, and we are working to try to find a way to make this really available year-round, as I said. So more information, go to ascpodcast.com. Sue, we forgot to mention that if you're interested in all those things at ASCA, go to the ascassociation.org website. I can't believe it's not in the script there. And, please, we always want to encourage people to become a patron member of the podcast. Patron members, also known as ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. Resources include some of our virtual conferences, links to important websites, policies and procedures, forms, drill kits, example drills that you can perform, discounts and services and books, and access to AEU credits on a quarterly basis. Membership fees help to defray the cost of producing the podcast, which seems to be growing every day as we wear out our equipment here, including our research staff, travel costs when we actually do travel, now equipment costs and production costs. For more information, you may visit asc-central.com or go to ascpodcast.com and follow the links for becoming a member. So that's it for this episode of the ASC Podcast with John Goehle. Join us again, please, and consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors: Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and Intalere. For more information about our sponsors, visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.